Alterations of musculoskeletal function. A fracture is a break in the continuity of a bone and is classified in several ways. It can be complete or incomplete, open or closed, and described by the direction of the fracture line, such as spiral or transverse. Some fractures are specific to children, like Greenstick or torus fractures, while others, like pathologic or stress fractures, are associated with disease or repetitive strain. Recognizing the type of fracture helps guide treatment and predict healing. This image shows various types of fractures, from linear and oblique to more complex comminuted breaks. Each fracture type has unique characteristics, such as displacement or fragment pattern. Greenstick fractures are incomplete and commonly seen in children, while spiral fractures are often the result of twisting forces. Visual aids like this one help clarify the differences in bone injury patterns. Bone healing occurs through two primary mechanisms: direct or primary and indirect or secondary healing. Direct healing typically requires surgical fixation and proceeds without callus formation. Indirect healing, more common in non-surgical cases like casting, involves the formation of a callus, followed by remodeling into mature bone. Both pathways result in bone repair, but differ in biological process and timeline. This illustration outlines the phases of indirect healing. The body first forms a hematoma, followed by procallus and callus formation. Over time, this immature bone is replaced and remodeled into structurally strong tissue. The success of this process depends on adequate blood supply, immobilization, and overall patient health. Common signs of a fracture include unnatural alignment, swelling, muscle spasm, and pain. Patients may also experience numbness or impaired movement due to nerve involvement. Treatment may involve immobilization, traction, closed manipulation, or open reduction with internal or external fixation. Improper healing can lead to complications such as non-union, delayed union, or malunion. A dislocation occurs when bones in a joint lose all contact with each other, while a subluxation is a partial loss of contact. Both can result from trauma, joint instability, or conditions like rheumatoid arthritis. These injuries often accompany fractures or ligament tears. Proper realignment and stabilization are critical to prevent long-term joint damage. Soft tissue injuries include strains, sprains, and avulsions. A strain involves a tear in a tendon or muscle, while a sprain is a ligament injury. An avulsion is when a tendon or ligament detaches completely from its bone attachment. These injuries range in severity and often require prolonged healing and rehabilitation. Tendon and ligament injuries may take over 3 months to regain full mechanical stability. They are typically painful and associated with swelling, joint instability, or dislocation. Visual changes in contour or movement are also common. Early diagnosis and guided rehabilitation are essential to restore function and prevent recurrence. Tendinopathies involve tendon inflammation, often from overuse. Epicondylopathies are specific types, named by their location. Lateral epicondylopathy is known as tennis elbow, while medial epicondylopathy is called golfer's elbow. Treatment includes rest, ice, physical therapy, and sometimes injections or bracing. Bursitis is the inflammation of a bursa, a fluid-filled sac that reduces friction between tissues. It commonly occurs over bony prominences or where muscles and tendons move over bones. Causes include repetitive use, excess pressure, or direct trauma. Pain and limited movement are common symptoms, especially in the shoulders, elbows, hips, or knees. This image shows inflammation around a joint affected by bursitis. The bursa becomes swollen and tender, restricting mobility and causing discomfort with movement. Bursitis can be acute or chronic depending on the underlying cause. Treatment focuses on rest, anti-inflammatory medications, and avoiding aggravating activities. A muscle strain occurs when a muscle is stretched beyond its capacity, often during sudden, forceful movements. Strains may also involve tendon fibers and typically present with pain, swelling, and limited function. Healing occurs in three phases: destruction, repair, and remodeling. Early intervention can minimize scar formation and restore strength. Myositis ossificans, or heterotopic ossification, is a rare complication of muscle injury where bone forms within soft tissue. It is often associated with burns, orthopedic surgery, or trauma, especially in young athletes. The affected limb may become stiff and deformed due to this abnormal calcification. Imaging and rest are key to diagnosis and management. Rhabdomyolysis is a serious condition where muscle tissue breaks down, releasing myoglobin into the bloodstream. This pigment can clog the kidneys and lead to acute renal failure. The classic triad includes muscle pain, weakness, and dark urine. It's a medical emergency that requires aggressive fluid replacement to protect kidney function. Rhabdomyolysis is diagnosed when creatine kinase (CK) levels are elevated, usually 5 to 10 times the normal limit. Kidney failure becomes likely when CK levels exceed 15,000 units/L. The main goals of treatment are to maintain urine output and prevent electrolyte imbalances. Early recognition can prevent life-threatening complications. Compartment syndrome occurs when increased pressure within a muscle compartment restricts blood flow. This can happen after fractures, crush injuries, or tight casts. The resulting muscle ischemia leads to swelling and further pressure, potentially causing muscle and nerve death. Immediate evaluation is necessary to prevent permanent damage. The 6 P's of compartment syndrome are pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. Volkmann contracture is a potential long-term complication involving muscle and nerve damage. Diagnosis is confirmed by measuring intracompartmental pressure. Surgical fasciotomy is needed when pressure exceeds 30 mm Hg. Malignant hyperthermia is a life-threatening reaction to certain anesthetics. It's triggered by genetic mutations that cause uncontrolled muscle contraction and hypermetabolism, leading to rigidity, extreme fever, and rhabdomyolysis. Without prompt treatment with dantrolene, this condition can be fatal. Preoperative screening and family history are critical to prevention. Bone disorders may arise from metabolic, infectious, or genetic causes. Common conditions include osteoporosis, osteomalacia, Paget disease, and osteomyelitis. These disorders affect bone density, strength, and remodeling capacity. Early diagnosis helps prevent fractures and long-term disability. Osteoporosis is a metabolic bone disease marked by low bone mass and structural deterioration, leading to increased fracture risk. It occurs when bone resorption outpaces bone formation. Bones become fragile and are more likely to break from minimal trauma. Vertebrae, hips, and wrists are common sites of osteoporotic fractures. This slide shows bone density loss under the microscope. In osteoporotic bone, trabeculae are thin and disconnected. Loss of density compromises the mechanical strength of bone. Diagnosis relies on imaging and bone density testing. Potential causes of osteoporosis include hormonal imbalances, vitamin D deficiency, medications, and low physical activity. Conditions like hypothyroidism, Cushing's syndrome, and hypogonadism contribute to bone loss. Body weight and nutritional status also play a role. Fractures are the most serious complication. Postmenopausal osteoporosis affects middle-aged and older women. It's driven by estrogen deficiency, which disrupts the balance between osteoclasts and osteoblasts. Bone loss accelerates during the first few years after menopause. Prevention includes calcium, vitamin D, and weight-bearing exercise. Secondary osteoporosis results from other health conditions like endocrine disorders, medications, or immobilization. Regional osteoporosis may be confined to one limb or joint and is often related to disuse. Though it can be transient, it still increases the risk of local fractures. Treating the underlying cause is essential. Glucocorticoid-induced osteoporosis is a major secondary form. These medications enhance osteoclast survival while suppressing osteoblast function, leading to bone loss. Age-related osteoporosis also contributes, especially with reduced activity. Men have greater baseline bone mass, so they experience fractures later than women. This image emphasizes skeletal changes in advanced osteoporosis. Vertebral compression and kyphosis are common in older adults. Early screening and intervention can prevent deformity and disability. Bone loss may be silent until a fracture occurs. Advanced cases often present with vertebral fractures, height loss, and spinal curvature. These structural changes can impair respiratory function and mobility. Pain may be chronic and impact quality of life. Regular monitoring with imaging helps track progression. Advanced cases often present with vertebral fractures, height loss, and spinal curvature. These structural changes can impair respiratory function and mobility. Pain may be chronic and impact quality of life. Regular monitoring with imaging helps track progression. Dual energy X-ray absorptiometry, or DXA, is the gold standard for diagnosing osteoporosis. It measures bone mineral density and helps assess fracture risk. A newer tool, the trabecular bone score, or TBS, evaluates bone microarchitecture to enhance diagnostic precision. These tools guide treatment decisions and monitor therapy effectiveness. Osteoporosis screening is essential, especially in postmenopausal women and older adults. DXA and TBS assessments help identify those at high risk before fractures occur. Early intervention with lifestyle changes and medications can preserve bone mass. The goal is to reduce fracture risk and maintain mobility. Osteomalacia is caused by a vitamin D deficiency, leading to poor mineralization of newly formed bone matrix. The bone becomes soft and weak, resulting in deformities, pain, and increased fracture risk. Though similar to osteoporosis, osteomalacia is due to impaired calcification, not bone loss. Treatment focuses on replacing vitamin D and correcting the underlying cause. Paget disease, also known as osteitis deformans, is a chronic condition involving excessive bone remodeling. Spongy bone is broken down and rebuilt in a disorganized way, leading to enlarged and softened bones. It often affects the pelvis, femur, skull, and spine. Although many cases are asymptomatic, others may cause bone pain, deformities, or neurological complications. Osteomyelitis is an infection of the bone, most commonly caused by Staphylococcus aureus. Bacteria reach the bone through the bloodstream, especially from infections in the skin, ears, or sinuses. Symptoms may be subtle at first: fever, malaise, and bone pain. Without treatment, the infection can become chronic and difficult to eradicate. Contiguous osteomyelitis occurs when bacteria spread from an adjacent soft tissue infection, often due to open fractures, wounds, or surgical contamination. Patients may present with swelling, redness, and local pain. Systemic signs are usually mild but should not be ignored. Early intervention prevents bone destruction. Brody abscesses are localized pockets of infection seen in chronic osteomyelitis. They often appear in the long bones and can persist for years. Treatment includes long-term antibiotics, surgical debridement, and in some cases, hyperbaric oxygen therapy. Chronic infections may lead to bone necrosis or even amputation if untreated. This slide summarizes management for both acute and chronic osteomyelitis. Imaging, lab tests, and cultures help confirm the diagnosis. Treatment is aggressive and prolonged due to the difficulty of getting antibiotics into infected bone. Surgical cleaning and stabilization are often necessary for recovery. Joint disorders are either non-inflammatory, like osteoarthritis, or inflammatory, like rheumatoid arthritis and gout. New research shows that even osteoarthritis may involve mild inflammation. Proper classification is important for selecting treatment. Both types can cause joint pain, stiffness, and deformity. Osteoarthritis is a degenerative joint disease marked by loss of articular cartilage, subchondral bone changes, and mild synovitis. New bone forms at the joint margins, creating osteophytes. The condition worsens over time and is especially common in weight-bearing joints like the knees and hips. It's the most prevalent joint disease in aging adults. Risk factors for osteoarthritis include aging, joint trauma, mechanical stress, and obesity. Repetitive use of joints accelerates cartilage breakdown. The disease tends to affect one or two major joints rather than being widespread. Preventive strategies include weight management and avoiding repetitive joint strain. Osteoarthritis is characterized by cartilage degeneration, formation of bone spurs, and joint capsule thickening. Damage is often localized to areas with the greatest mechanical load. Mild inflammation may be present, but it's not the primary driver of disease. This progressive condition leads to pain and reduced joint mobility over time. Clinical signs include joint pain that worsens with activity, morning stiffness that improves with movement, and joint enlargement. In the hands, Heberden nodes and Bouchard nodes may develop. As the disease progresses, range of motion becomes limited and deformity or partial dislocation can occur. Surrounding muscles may weaken due to disuse. This slide shows radiographic and clinical examples of osteoarthritis. Joint space narrowing, subchondral sclerosis, and osteophyte formation are hallmark findings. Affected joints may appear swollen and misaligned. Imaging confirms diagnosis and tracks disease progression. Treatment begins conservatively with exercise, weight loss, and analgesics or anti-inflammatory medications. Nutritional supplements like glucosamine and chondroitin are sometimes used. For severe cases, surgical options include joint realignment or joint replacement with prosthetics. The goal is to reduce pain, improve function, and slow progression. Inflammatory joint diseases cause destruction of the synovial membrane and articular cartilage. Unlike osteoarthritis, they involve systemic inflammation, often triggered by autoimmune processes. The most common types are rheumatoid arthritis, ankylosing spondylitis, and gout. These conditions require immune-modulating therapy. Rheumatoid arthritis, or RA, is a systemic autoimmune disease that primarily targets synovial joints. It causes chronic inflammation, cartilage destruction, and bone erosion. The exact cause is unknown, but genetic predisposition and environmental factors play roles. Rheumatoid factors RF and ACPAs are antibodies often present in affected individuals. Joint destruction in RA results from three main mechanisms: activation of neutrophils, cytokine-driven enzymatic breakdown, and formation of pannus, an abnormal layer of granulation tissue. T cells and fibroblasts also contribute to synovial thickening. These processes lead to irreversible damage if left untreated. This image depicts joint deformities typical of advanced RA. Hands may show ulnar deviation, swan neck, or boutonniere deformities. The wrists, knees, and cervical spine are often involved. Structural damage progresses with inflammation and repeated flare-ups. Raw has a gradual onset and may start with fatigue, low-grade fever, weight loss, and generalized joint stiffness. Joints become painful, tender, and swollen, especially in the morning. Rheumatoid nodules, firm lumps under the skin, can develop. Kaplan syndrome occurs when nodules are seen in the lungs along with pneumoconiosis. This slide further illustrates systemic symptoms and joint involvement. Raw can also affect the lungs, eyes, skin, and vascular system. Early and aggressive treatment is essential to preserve joint function. Disease-modifying antirheumatic drugs, or DMARDs, are the cornerstone of therapy. Raw is diagnosed through clinical symptoms and the presence of autoantibodies, such as rheumatoid factor, or RF, or anti-citrullonated protein antibodies, or ACPAs. Early use of disease-modifying antirheumatic drugs, or DMARDs, slows progression and preserves joint function. Biologic agents may also be used to target specific immune pathways. Early diagnosis and aggressive treatment are crucial to prevent permanent disability. Ankylosing spondylitis, or as is an inflammatory arthritis that primarily affects the spine and sacroiliac joints. It causes joint stiffening, fusion, and loss of mobility. As belongs to a group of diseases called spondyloarthropathies and is systemic and autoimmune in nature. The primary site of pathology is the enthesis, where tendons and ligaments attach to bone. While the exact cause is unknown, there is a strong link to the HLA-B27 antigen. The disease starts with inflammation of fibrocartilage, especially in the vertebrae and sacroiliac joints. Over time, scar tissue forms, ossifies, and fuses the joints. This can severely limit spinal flexibility and cause deformity. Symptoms usually begin in early adulthood with low back pain, morning stiffness, and limited motion. As the disease progresses, patients lose lumbar lordosis and develop thoracic kyphosis. Pain may improve with activity but worsen with rest. Early signs are often mistaken for mechanical back pain. This diagram shows advanced as, where the spine appears rigid and fused, often described as a bamboo spine on imaging. Spinal fusion can impair posture and breathing. Physical therapy is critical to maintain mobility and prevent contractures. Regular exercise is recommended to preserve spinal flexibility. Sacroiliitis, or inflammation of the sacroiliac joints, is a hallmark finding on imaging. Treatment includes non-steroidal anti-inflammatory drugs, or NSAIDs, for pain and physical therapy to preserve motion. In advanced cases, biologic therapies targeting TNF-alpha or IL may 17th be used. Early intervention can delay progression and improve quality of life. Gout is an inflammatory arthritis caused by the buildup of uric acid crystals in the joints. This occurs when uric acid levels are elevated in the blood, known as hyperuricemia. The crystals trigger a strong inflammatory response, resulting in acute joint pain, swelling, and redness. Gout most often affects the big toe, but other joints can be involved. Risk factors for gout include male sex, aging, high intake of red meat, alcohol, and fructose, and obesity. Reduced kidney function can also impair uric acid elimination. Some medications, such as diuretics, may raise uric acid levels. Genetic predisposition also plays a role. Gout presents with sudden, severe joint pain, often beginning at night. Joints become red, hot, tender, and swollen. Tophi, which are deposits of urate crystals, can develop in joints and soft tissues. Gout may also lead to kidney stones and chronic renal disease if left untreated. There are 3 clinical stages: Asymptomatic hyperuricemia, where uric acid is elevated without symptoms. Acute gouty arthritis, with sudden attacks of joint pain. And tophaceous gout, the chronic form with visible crystal deposits. Early diagnosis and uric acid lowering therapy can prevent joint damage. Lifestyle changes are also crucial for management. Trauma is the most common trigger for an acute gout attack. The first metatarsophalangeal joint, the base of the big toe, is affected in over half of initial cases. Other joints such as the heel, ankle, knee, wrist, or elbow can also be involved. People with gout are at much higher risk for renal stones and joint damage over time. During an acute attack, the joint becomes red, hot, swollen, and extremely painful. Systemic signs of inflammation may also occur, including fever, leukocytosis, and elevated sedimentation rate. If untreated, urate crystals continue to deposit, forming tophaceous nodules that limit mobility. Chronic gout may lead to deformities and permanent joint damage. This image shows tophi forming around the joints, chalky deposits of uric acid crystals. These deposits are visible under the skin and can be disfiguring. Early intervention with uric acid-lowering drugs, such as allopurinol, can prevent this progression. Managing dietary triggers and comorbidities is also essential. Contractures are limitations in joint movement due to shortened muscles or soft tissue. Physiologic contractures are reversible and result from muscle fatigue or metabolic changes. Pathologic contractures, however, are permanent and caused by muscle spasm, weakness, or fibrosis. They interfere with function and often require physical therapy or surgery to improve range of motion. Stress-induced muscle tension often manifests as neck stiffness, back pain, and headaches. It's frequently associated with chronic anxiety or psychological stress. This tension arises from abnormalities in the central nervous system and autonomic regulation. Mind-body therapies, stretching, and posture correction can provide relief. Fibromyalgia is a chronic pain syndrome involving diffuse musculoskeletal pain, fatigue, and tender points. Patients often report heightened sensitivity to touch, but no inflammation is present. Other symptoms include non-restorative sleep, anxiety, and depression. Diagnosis is clinical and often misunderstood due to its subjective nature. Around 80 to 90% of fibromyalgia patients are women, often diagnosed between ages 30 and 50. While the exact cause is unclear, evidence suggests involvement of genetic, neurochemical, and environmental factors. Studies link it to changes in serotonin, dopamine, and catecholamines, affecting pain perception and mood. Family history may also increase risk. The hallmark symptom is widespread, chronic pain that is disproportionate to any observable tissue damage. Patients also report fatigue, cognitive dysfunction, and sleep disturbance. Diagnosis is based on a combination of widespread pain index, or WPI, and symptom severity, or SS scores. Objective tests are not typically helpful. This diagram shows common tender point locations, such as the neck, shoulders, chest, hips, and knees. Treatment involves multimodal therapy, medications like SNRIs, physical activity, cognitive behavioral therapy, and stress reduction. While there is no cure, many patients experience improvement with structured care. Chronic fatigue syndrome, also called myalgic encephalomyelitis, is a complex disorder marked by profound fatigue, cognitive impairment, and unrefreshing sleep. Symptoms worsen with exertion and do not improve with rest. It may be linked to immune dysfunction, viral infections, or central nervous system hypersensitivity. Diagnosis is clinical and often delayed due to overlap with other conditions. Chronic fatigue syndrome leads to a significant reduction in daily functioning. Patients may experience memory problems, joint pain, and headaches, often worsened by exertion. There is no definitive diagnostic test, and management focuses on energy conservation, graded exercise, and supportive care. Many patients benefit from a structured, multidisciplinary approach. Some muscle disorders stem from channelopathies or inherited defects in ion channels. Myotonia is delayed relaxation after contraction, resulting in stiffness or weakness. Periodic paralysis involves episodes of temporary weakness or paralysis due to abnormal depolarization, often linked to potassium levels. These conditions can be triggered by stress, exercise, or diet. Muscle performance is heavily influenced by hormonal balance, especially thyroid hormone, which regulates protein synthesis and electrolyte balance. Endocrine disorders may lead to muscle weakness, changes in muscle mass, or altered contractility. Symptoms often resolve with correction of the underlying hormonal imbalance. Some muscle diseases are linked to energy metabolism defects, such as McArdle disease, a type of glycogen storage disorder. Patients experience muscle cramps and fatigue at the start of exercise due to an inability to break down glycogen. In Pompe disease, glycogen accumulates in tissues, causing organ damage and progressive weakness. Early diagnosis is key to managing symptoms and preventing complications. AMP deaminase deficiency is another energy-related muscle disorder. It leads to exercise intolerance, muscle pain, or fatigue. Lipid storage myopathies disrupt fatty acid metabolism and may cause liver failure, seizures, or even sudden death. These conditions are rare but important to recognize due to their serious consequences. Myositis is inflammation of skeletal muscle caused by viruses, bacteria, parasites, or autoimmune reactions. Infections like trichinosis, toxoplasmosis, and tuberculosis can infiltrate muscle and cause pain, swelling, and weakness. Diagnosis may involve lab tests, biopsy, and imaging. Treatment depends on the underlying infection or inflammation source. Polymyositis and dermatomyositis are autoimmune myopathies causing proximal muscle weakness, especially in the hips, shoulders, and neck. In sporadic inclusion body myositis, weakness occurs in the wrists, fingers, and thighs. Patients may struggle with walking, grasping, or even swallowing. Treatment includes immunosuppressive therapy and supportive care. Alcohol abuse is the most common cause of toxic myopathy. Acute cases result in painful muscle weakness and swelling, often after binge drinking. Chronic alcohol use leads to progressive weakness over time. Other toxins include statins, antimalarials, steroids, and narcotics. Symptoms range from asymptomatic weakness to severe muscle pain and necrosis. In some cases, patients may develop rhabdomyolysis with life-threatening complications. Treatment focuses on removing the offending agent, improving nutrition, and providing supportive care. Monitoring for kidney injury and electrolyte imbalance is also important. Bone tumors can originate from bone cells, cartilage, fibrous tissue, or marrow. They are classified by tissue origin: osteogenic, chondrogenic, collagenous, or myelogenic. While some are benign, others are malignant and may invade surrounding structures. Early detection is essential to prevent complications. Malignant bone tumors show certain features under the microscope: high nuclear to cytoplasmic ratio, irregular borders, excess chromatin, and a high mitotic rate. These signs help differentiate cancerous tissue from benign lesions. Biopsy and imaging guide diagnosis and treatment planning. Patterns of bone destruction are categorized as geographic, moth-eaten, or permeated. These radiographic patterns suggest the aggressiveness of the lesion. Symptoms are often vague: pain, swelling, or pathological fractures. Many patients initially attribute symptoms to trauma or arthritis. This slide visually compares patterns of bone destruction seen in various tumors. Geographic patterns are usually seen in slower-growing tumors, while moth-eaten and permeative patterns suggest rapid growth and malignancy. Identifying these patterns helps prioritize urgency of treatment. Osteosarcoma is the most common malignant bone-forming tumor, mostly affecting people under 20 or those with prior radiation exposure. It often arises in the metaphysis of long bones, especially around the knees. The tumor forms osteoid tissue, seen as thickened masses or streamers. Aggressive chemotherapy and surgery are standard treatments. Chondrosarcoma is a cartilage-forming tumor that usually affects middle-aged and older adults. It commonly arises in the metaphysis or diaphysis of long bones and may infiltrate surrounding soft tissues. These tumors grow slowly but can be resistant to chemotherapy. Surgery is the primary treatment approach. Fibrosarcoma is a collagen-producing tumor that forms a firm, fibrous mass containing malignant fibroblasts. It typically arises in the metaphyses of the femur or tibia and frequently spreads to the lungs. Symptoms may include pain, swelling, and restricted joint motion. Early detection improves prognosis. Myelogenic tumors originate from bone marrow cells. One example is the giant cell tumor, known for its osteoclastic activity and extensive bone resorption. It most often affects the epiphysis of long bones like the femur, tibia, or humerus. Although slow-growing, it can be locally aggressive and often requires surgical removal. Rhabdomyoma is a rare benign tumor of striated muscle, typically occurring in the tongue, larynx, heart, or neck muscles. Most are found incidentally and cause minimal symptoms. Surgical removal is usually curative. These tumors are significantly less common than malignant forms. There are three main subtypes: anaplastic, embryonal, and alveolar. Embryonal rhabdomyosarcoma is the most common and tends to respond better to therapy. Alveolar and anaplastic forms are more aggressive and carry a poorer prognosis. Early diagnosis and a multidisciplinary treatment approach are essential for improving survival outcomes.